Thank you very much for that introduction and for the invitation to speak to you today. I'll be speaking about how we look at oral therapies for the treatment of HIV in the treatment naive, as well as the HIV suppressed patient who wishes to change to a different regimen for various reasons. These are my significant disclosures. Sadly, and for obvious reasons, I'm unable to attend the European meeting in person this year. I live in Toronto, Canada, in the south central part of the province of Ontario. I invite you to come visit us in Canada once the borders reopen. Approximately 2 hours from where I live in southwestern Ontario are many small towns with names of European cities. So my European trip this year has consisted of a 5-hour drive in the countryside of Ontario. When we are about to initiate treatment for HIV, or for that matter, any disease, there are many things to consider. There are medical considerations. What are the options, or even what are the best options? Are the medications safe, tolerable, and easy to administer? Does starting the medication have any long-term benefit? There are patient considerations as well. Does the patient understand the rationale for treatment? Do they buy into the need for therapy and understand all the options? Do they understand the benefits? In the case of HIV treatment, not only to themselves, but to others around them. And then there are the social economic considerations. Also, what else is happening in their lives? Are their lives stable or are they chaotic? Can they afford the medications? Can we help them ensure adherence and other determinants that are important for maintenance of good health? We know that generally speaking, when people start their HIV medication, they do a great job at taking it. The number of individuals globally taking antiretroviral medication has increased for many reasons, including availability, affordability, tolerability, as well as low pill burden and the ease of administration. The concern with this cascade, however, is that it is not 100%. Not everyone in care is on treatment, and not everyone on treatment is undetectable. But the drop off in the cascade is becoming less and less, and most people who take antiretroviral therapy today do so successfully. We have a lot of medication options available to us. When I started treating HIV many years ago, people had daily pill burdens that looked like this picture. And today it's a very different story. We've all seen charts similar to this one in various forms. Today we have many options for our patients, and so how do we choose what is the best option? This can be challenging, especially with new treatment options continuing to arrive on the scene. This is when we turn to guidelines to help us, because just because a drug is new or a class is new does not necessarily mean that it's better. There are different guidelines depending on where you practice. There are the IAS guidelines, the DHHS guidelines, and the EACTS guidelines, to name the big three. People often ask why the guidelines are different when they all have the same data to look at. It's not really that the guidelines are different. For the most part, they agree more than they disagree. The differences occur when certain studies or conclusions are weighted differently, and for that reason, even practicing in Canada, we tend to rely on the EACTS guidelines because they have to be appropriate for a much broader base, taking into account many different countries with different budgets and different populations. So in many ways, I think that the EACTS guidelines are the broadest interpretation of the clinical trial data. With the available drugs today, there are over 1,000 possible combinations, but only a fraction of these have been formally studied in randomized controlled trials. This is why we rely on treatment guidelines. So for the rest of my talk, and because this is a European conference, I will be referencing the European guidelines. This slide shows the recommended initial regimens for treatment-naive adult patients. The guidelines favor the initiation of treatment with unboosted integrase inhibitors that also have a high genetic barrier to resistance, most notably Dolutegevir or Bictegravir as the third agent. Raltegravir is also on the preferred list. These are combined with NRTI drugs, most often one of abacavir 3-TC, Tenofovir 3TC, Tenofovir FTC, or Taft FTC. Equally on the preferred regimen list is Dovato, which is Dolutegevir with only one NRTI drug, 3TC, but there are a couple of caveats in that it is not recommended for individuals with very high viral loads, that is over 500,000 copies, CD4 counts less than 200, and is not suitable if you believe in the benefits of rapid starts, as you need to ensure patients are hepatitis B surface antigen negative prior to starting this regimen. Other recommended regimens include 2 NRTI drugs in combination with an NNRTI, such as rilpivirine or doravirine, or 2 NRTI drugs in combination with a boosted protease inhibitor, such as darunavir and cobicistat. There are then alternative regimens as well, and I will refer you directly to the guidelines to review these, as there are certain caveats associated with each of them. This is a slide that I borrowed because it's very clear and it certainly exceeds my PowerPoint creative abilities. This slide shows 4 of the preferred regimens, which are consistent across all guidelines and probably make up the bulk of our new starts today. All these regimens have demonstrated greater than 80 to 90% viral suppression and have been in comparison studies with no regimen shown to be inferior to any of the others. The fact that they are included on all guidelines reflects their good clinical and safety data. They are also 1-tablet daily regimens with good efficacy and tolerability, and no treatment-emergent resistant mutations have occurred on any of these regimens, which cannot be said about some of the other regimens. The question then arises as to how do we choose between each of these regimens? Where we might be seeing some difference between these regimens is in the area of weight gain. The ADVANCE trial, performed in South Africa, enrolled over 1,000 patients on 3 regimens: Taft Dolutegevir versus Tenofovir Dolutegevir versus Tenofovir efavirenz. It showed that females gained more weight than men, approximately 2 kilograms, and the greatest weight gain was seen in the Taft Dolutegevir arm, followed by the Tenofovir Dolutegevir and the Tenofovir efavirenz arm. The current debate is, does Tenofovir, TDF, prevent weight gain, maybe through appetite or gastrointestinal side effects, versus does Taft cause weight gain? We do see some weight gain in our patients on PrEP, but not to the same degree as seen on patients on treatment. This slide shows weight gain in many studies and comparisons over time. We also see Taft has more weight gain than TDF over time, with abacavir being closer to TDF in terms of weight gain. Women generally gained more weight than men, and women of color gained more weight than women not of color. BIC and dolutegravir saw similar weight gains between the 2 of them. There's little data on weight in Dovato from the Gemini study. There seemed to be a little more weight gain when Dovato was compared to dolutegravir tenofovir FTC group. So again, the question is, does tenofovir promote lower weight, or does dolutegravir cause increased weight? More people in the dolutegravir 3TC arm who were overweight at baseline did go on to become obese than patients in the other arm. The choice of regimens for pregnant females is a little different. There is the need not only to suppress the virus, but to suppress the virus quickly and maintain suppression at least for the duration of pregnancy. The regimen needs to be tolerable and safe to mom and baby, both during pregnancy, but also looking forward to breastfeeding, etc. TAF is not recommended mainly because of the lack of data, but if a patient gets pregnant while on TAF, it is probably reasonable for them to stay on it and to continue. Dolutegevir has been shown to have the most pregnancy data to date. Dolutegevir was part of a large study performed in Botswana that showed a signal related to neural tube defects, but this signal has decreased over time. Boosted protease inhibitors are not generally recommended in pregnancy, first because cobicistat does not boost the PI as consistent as ritonavir, and the drug levels in the 2nd and 3rd trimesters are often subtherapeutic due to changes in protein and fluid balance that occur during pregnancy. When making a modification to a regimen of a successfully suppressed patient, the goal should be to eliminate or improve adverse events, facilitate treatment of comorbid conditions, and improve quality of life. The primary concern is to maintain virologic suppression, and to this we need to consider if the patient has developed mutations to any drug previously or never acquired any known resistance mutations. Changes can be considered to decrease or prevent long-term toxicity, such as changing Tenofovir to Taft, to avoid drug interactions, such as decreasing the use of cytochrome P450 inhibitors, regimen simplification, either by lowering the number of active agents or pill burden, and of course, cost, sadly, is now a consideration which we need to examine further. So what about the cost? This is a graph which illustrates the cost of HIV antiretroviral therapy in the United States. Pricing of medications is very complicated. The recommended regimens are often more expensive because they are newer and bring added benefits over previous regimens, but always remember that more expensive does not necessarily mean better. In this curve, we see the cost of HIV medications has steadily increased year over year, but this reflects not only the cost of the drug, but the volume of prescriptions as more and more people are taking antiretroviral medications. The Dublin Declaration on Partnership to Fight HIV/AIDS in Europe and Central Asia was adopted in 2004 and was the first in a series of regional declarations which emphasized HIV as an important political priority for the countries of Europe and Central Asia. There are many goals of the declaration, but key is to provide increased and results-based financial and technical resources to scale up access to prevention, care, and sustained treatment, including effective low-cost treatments such as generic medications. In essence, it's trying to make ARTs affordable to everyone, knowing different countries in the EU, for example, will have different abilities to absorb the cost burden. As you can see in this graph from that study, the significant differences of the mean cost of ART per patient per year in many different countries, and this has a significant impact on individual access to care. This is one of the reasons that the EACTS guidelines are so inclusive of regimens to allow recommended treatment regimens to be given to all who need it. So in conclusion, integrase inhibitors are the preferred regimens. They have a high barrier to resistance, are well tolerated, have rare drug interactions, and are generally low pill burden regimens. There is caution about weight gain, and we did not talk about some of the other possible issues such as sleep disturbance and mood alterations. NRTIs have a lower barrier to resistance but have less weight gain, and this for many individuals is an important factor. Protease inhibitors have many potential drug interactions, and this can pose significant concerns in an aging population. They have more side effects and have less efficacy in most comparative trials that include integrase inhibitors. 2 versus 3 drug regimens are an option for less medication, but there is less clinical evidence outside of clinical trials. But the use is increasing in the clinic. They also may be cheaper, but this is uncertain at this point in time. And finally, there is the new ongoing debate about Taft versus Tenofovir. There is good rationale for Taft as it has less renal and bone consequences, but weight remains an issue. Does Taft increase weight or does Tenofovir decrease weight? In the end, cost may dictate which of these regimens most patients use. And finally, I would like to thank you for your attention to this presentation. I wish you well. Please stay safe, be responsible, wear your mask, and practice social distancing where possible. If you are a cat lover like myself, you will appreciate that cats are experts in the art of social distancing, and they are working tirelessly for us to go back to the office and leave them alone. Thank you very much for your attention.